Over to you, Indira.
Good evening, everybody. Good evening, fellows. Once again, and I'm sure you're getting enriched with all this experience by stalwarts on ECMO. Now, pediatric ECMO, why this is important? I know Dr. Pranay shared the delegates, and we saw that almost nearing 50% are also pediatric intensivists. Not only that, so does it mean that adult intensivists do not have to listen to this talk? No, because I know even Arpan, many other adult intensivists are also doing pediatric ECMO. So we need everybody to do ECMO to save lives. And no disclosures. And as Dr. Arpan said, we all want to create awareness. That's the only disclosure for that we have. We want to create awareness of ECMO. One second, sorry. Yeah, so pediatric ECMO, you all would have seen this slide. We are not sure. Just could you give me a brief minute? Okay, so ECMO in pediatric ARDS, is it overrated or underutilized? And what we have realized with experience that it is usually initiated late. We are debating whether to ventilate on these high pressures, whether to go for HFO, or whether we should cannulate. And cannulation generally is pretty late. And by then you have multi-organ dysfunction, the ventilator-induced lung injury has set in. So the more you delay, the longer it takes on ECMO and the lesser the chance of survival. So the earlier you institute it, the less of ventilator-induced lung injury, the earlier you can come off ECMO. And that's what we have learned from our experience. We all know it was started in neonates by Robert Bartlett, and you would have seen all this with a good success in pediatrics, about 50% survival to discharge. So you can imagine these were patients who would have had 100% mortality, and you have given them a chance, a 50% chance to go home. That is great. So what should we ask? And I think this holds true for both adults and pediatrics. What is the path ahead with ECMO? What's the quality of life that the patient will have? And is ECMO more likely to help or hurt? So if you can answer these questions, then it becomes more clear for you whether you should be doing ECMO. And we know that ECMO, these patients are the sickest of sick, 80% mortality to survival, and timing is everything. So what is the ideal time? The earlier, the better. But does it mean that after 14 days, you should not be, or after 10 days, you should not be instituting ECMO? In neonates, you can stretch it a little longer. In pediatrics, maybe within 10 days or so, but it all depends on how high the ventilator settings were before the patient went on ECMO. So if the patient was in very low ventilator settings, that doesn't count. So if the patient has been on high settings, you have to institute it much earlier. So you'll have to individualize, and there's no real cutoff time. So the PALIC-2, so in pediatrics, like you have your ARDS criteria in adults, in pediatrics, there's now this PALIC-2 guidelines for pediatric acute ARDS. And when we say severe ARDS, that is the OI of 16, or OSI, that is oxygenation, this is saturation index, where you don't use your PaO2, but you put your SaO2. So what are the recommendations of the latest guidelines on ECMO for ARDS? Failing response to treatment, when lung protective strategies fail and the cause is reversible, there is no strict criteria. So these are the indications, but there's really no strict criteria. You have to serially monitor your patient. What type of ECMO would you use? Veno-venous ECMO. Avoid hyperoxia, because that can cause reperfusion injury. And this is very, very important. Slow changes in PaCO2. So this is your blood gas targets. And mechanical ventilator strategies is generally lung protective strategy. So what is this OSI? So in kids, you need an arterial catheter, you need frequent sampling. In neonates, you could make them anemic with all the repeated sampling, and it's always intermittent. So this is a very nice index, where you replace the PaO2 with the SaO2, and this is how you calculate. Easy to remember, what you give by what you get. So what you give is your map into FiO2, what you get is your saturations, and that is your OSI. When you say severe ARDS, it's OSI more than 12. And of course, the same indications more than OI more than 25 or OSI more than 20 holds good. So what are the indications for pediatric ARDS ECMO? OI of 25. That itself has a 50% mortality. So many centers across the globe are instituting ECMO when your OI is already 25, so that you don't have much ventilator-induced lung injury. It's no longer wait till 40. And OI more than 25, not responding despite maximal ventilatory strategies, you're proning, there's rising lactate, need for vasoactive support. That means your RV is failing. PF ratio less than 100 or 150 with unsafe high vent settings, high ventilatory pressures on MAP more than 20 or 25, or this is on conventional, or more than 30 on HFOV. Severe pulmonary hypertension, so you're already on vasoactives for your RV dysfunction, lack of response to HFO, nitric prone, and of course, most important, the rate of deterioration and how quickly ECMO can be initiated. This is for hypoxemic respiratory failure. What if you have just isolated hypercarbic respiratory failure? Arpan was talking about ECOR. So there are indications in pediatrics like your asthma. So many centers in India also have initiated ECMO for 2-3 days for severe acute severe asthma, bronchiolitis. So because of your ventilation index, so when your PCO2 is very, very high and you're in very high settings, respiratory rate, so this is your ventilation index, that's more than 40 for 4 to 6 hours. This is used in neonates as well as in pediatrics. Now we have a patient on ECMO with ARDS with air leak. So air leak, what would you do? This is the best way you can rest your lungs. Rather than, and for patients with bronchopleural fistula, air leak, ARDS, just let the ECMO oxygenate, remove your CO2s, don't use your ventilator, reduce your pressures on the ventilator. You can even put the patient on TPs till the bubbling settles. And then slowly after 3-4 days, when the bubbling ceases, you can slowly start recruiting your lungs. Now, regarding chest tubes, a word of caution. Hemodynamic compromise, tension pneumothorax should be the only absolute indication for chest tube on ECMO. So if you're putting a patient on ECMO, it is better to get your chest tubes inserted before you heparinize and place the patient on ECMO, because we can convert a tension pneumothorax to hemothorax, and then your lung will never get inflated because all that will be sitting on the hemothorax will prevent expansion. Now, another indication, respiratory indications for ECMO in pediatrics, all your airway surgeries. Many of our kids have bad tracheomalacia, tracheal stenosis, and so all your tracheoplasty, etc., are done on ECMO. Then Dr. Madan mentioned for transplantation, your mediastinal mass biopsy, then any procedures like a BAL, we have alveolar proteinosis where they need, significant lavage. So all that ECMO can be used as a for short periods, just for that procedure. So there are a lot of indications, burns with ARDS, foreign body aspiration. So these are very unique indications in pediatrics. They have hydrocarbon. In India, we see kerosene aspiration and they keep blowing pneumos. So that's another indication. Pertussis, inhalation of baby powder, tracheobronchial trauma, and of course, difficult airway. So you can see ECMO is part of your ASA anesthesia algorithm for difficult airway. Now, trauma. Till now, we would think that if there is trauma, if there's a little brain bleed, you shouldn't be instituting ECMO because it will worsen the brain bleed. But this no longer holds good. And we've had patients in other centers also who had ARDS, lung contusion due to polytrauma, along with a little bleed in the brain and traumatic brain injury. And ECMO was instituted without heparinization. So remember, you can put patients on ECMO, you just run high flows, you don't have to give heparin in the initial few, maybe 48 hours or so, till you sort out all this, and at least you can keep the patient alive and not die due to your, so it should not mean that the patient dies due to ARDS because you're trying to save the brain and prevent the bleed. Immune compromised children. It is not a contraindication. Diffuse alveolar hemorrhage for leukemic patients who have a chance of a good quality of life after the ECMO. ECMO has been initiated world over. So immune compromised state is definitely not a contraindication. As you can see this title, immune compromised condition, what's in a name? Now, neonates. So it all started in neonates with Professor Robert Bartlett and meconium aspiration. This is actually Dr. Gangaram, Dr. Anil Sachdev had shared this in the group, ECMO Society of India group. This is a 4-hour-old neonate. So I think the youngest who was cannulated for PPHN, transported, and then is doing well off the ECMO, I think, and still on the ventilator. So very good survival. We had a patient with meconium aspiration syndrome who celebrated the first birthday 2 months ago. So meconium aspiration syndrome, PPHN, very good survival, and they need only VV ECMO. So if you have a dual cannula, that would be great for putting in the neck. Otherwise, you'll have to do a VA cannulation because you need good flows if you don't have the dual lumen cannula. So you can see the indications have expanded. There's contraindications are very, very few. So if there is no chance, no purpose, or no ability, then that is the contraindication. And ECMO can be performed without anticoagulation for short periods till bleeding is stabilized. Even in pediatrics, you just have to ensure that you run a little higher flows because chances of clotting are much more in peds. Now, for ARDS patients, what type of ECMO would you initiate? Is it VV, VA? So centers across the globe are using only veno-venous or dual lumen veno-venous for patients with pneumonia, ARDS, even those with shock. So because why are they in shock? Why are ARDS patients in shock? Because it's acute cor pulmonale. It's the RV that fails with acidosis, hypercarbia, hypoxemia. And the minute you put them on ECMO, we actually see them have all your inotropes. We are backing off all the inotropes, in fact, starting SNP because there is hypertension. So ECMO is great. Veno-venous ECMO is great for ARDS, even with shock. So this is a very important message. You don't need VA ECMO. But the key is what is the weight of the child? If the child's weight is less than 15 kilos, then your femoral vessels or neonate or an infant, your femoral vessels are very small. So even if the indication is for lung, for ARDS, meconium aspiration, for hypoxemia, you still will have to opt for a VA neck cannulation. It's more because you need the flows. It's not because of the type of ECMO. It's just that you need better flows and your femoral veins are very, very small. And so you can't use that. But if you have dual lumen cannulae, then that would be great. And that would be enough for patients with ARDS and hypoxemia. This was a patient who was actually cannulated by Dr. Madan and team in the maternity hospital, transported, and you can see the baby smiling, turned 1 year, 2 months ago. So VV dual lumen cannulation has become modality of choice for pediatric respiratory failure. Unfortunately, it's not available very freely in all centers in India. We do not have any experience. And this is a very important slide. So this was a patient, ARDS. Look at the PCO2s, triple digits, and the pH. So patient was put on ECMO. So there's enough evidence, and what the ECMO recommends is your drop in PCO2 should be very, very gradual. And this is in pediatrics. So in adults, it says about 14 millimeters per millimeters per hour of millimeters of mercury. But in pediatrics, not more than 25 for the first 3 hours. So it should be the rate of drop of PCO2 should be less than 25 in the first 3 hours and very gradual in the first 20 hours. Why? To prevent neurological complications, your seizures, stroke, hemorrhage, ischemia, and brain death. So this is extremely, extremely important. And we all know CO2 is very diffusible. The minute you turn up the sweep gas, the CO2s will plummet. So please, when you initiate ECMO, keep the sweep gas very low. Your aim is to reduce the CO2 very, very gradually. So that is very important. Prognostication scores, you have, if you want to explain to your families what are the risks, and this is a little more objective. So if you look at your ELSO website, you will get this. There are in adults, there are in neonates, P-PrEP, P-Rescuer. So this is not a prediction score for whether the patient should go on ECMO. It is more to counsel the families. What are the likelihood of survival of this child because of this risk factor? So it's a very objective way, and that helps in counseling families. It's not for patient selection. So how do we cannulate? I told you, in small kids, it is always VA and that neck. So we do open cut down, so expose the vessel and then do a Seldinger. So this is a semi-Seldinger, open cut down and Seldinger. So this is so that you don't injure the vessel. Now, if we use femoral vein, that is your VV cannulation in bigger, older kids, very important to choose your femoral drain cannula. If it does not reach your IVC here, and if it's still sitting in the femoral veins below, you will not get adequate flows. So please tell the perfusionist and your ECMO team what the weight of the child is and choose the largest cannula, the longest cannula that you can have so that you have very good flows. If you make a mistake in this first step and your cannulas are too short, this is what we paid, the price that you will pay, because the flows were inadequate. This is the drainage. You can see the dark blood from the femoral vein, then going into the ECMO and then to the internal jugular. But the flows were so less from this femoral vein. The patient, look at this patient, so bloated, and we couldn't wean off ECMO. So finally, we put another femoral vein drainage, venous cannula, so that we could get adequate drain. But this is a mistake, and we have learned that it is worth getting the right cannula at the first instance. So in small babies, neonates, VA ECMO neck for ARDS, as the femoral vessels are very small. Now, what type of ventilation? The same that was already discussed by Dr. Pranay yesterday. Ultra low tidal volume ventilation, plateau pressures, this plus 10, 10, 10, 10 is what we also follow. As you can see here, the rate, 40% FiO2, PEEP a little more if the patient is very bloated, and low rate. FiO2. Try to reduce the FiO2 of the ventilator, because every 0.1 increase in ventilator FiO2 was associated with 38% increase in mortality, which is very, very significant. And so reduce your FiO2. You don't really need to have very good SATs on VV ECMO, even 85. If the patient is perfusing well, if your hemoglobin is okay, that is fine. And if the patient is well sedated, which means the demand is also less. Fluid overload, that can worsen your hypoxemia. I've already mentioned yesterday, and that is associated with worse outcomes. So try to get the patient very negative after the initial period of shock. So in the first 48 hours, what do we do in pediatrics? We keep them deeply sedated and paralyzed, because we don't want the child moving and then, dislodging the cannula, putting on control mode ventilation. After 48 hours, after we ensure that the sedation is on board and there's less likelihood of, the child pulling out the cannula, we stop paralysis and ensure that the patient doesn't have ventilator dysynchrony, just on some sedation, negative fluid balance. After 5 to 7 days, lighten the sedation, start your spontaneous mode. So it all depends on how fast the lungs are improving. You'll have to individualize, plus or minus tracheostomy, depending on the trajectory that this patient will go. And hypoxemia, the same troubleshooting. We do not target a number of hemoglobin. So we don't want to unnecessarily give blood product, PRBCs. Even 9 or 10 is good enough for us. Reduce the demand, and please watch for recirculation. Now, kids are very smaller. So when you use your femoral and your internal jugular, there is a high chance of the cannula being very close to each other. So there could be a lot more recirculation, which is contributing to your hypoxemia. So discuss with your surgeon. And pump flow, try not to increase too high pump flows, because there can be a lot of hemolysis. Now, are we PEEP-phobic? If the patient is bloated and you want to slowly recruit your lungs after a few days, you want to wean the patient, try to keep increasing your PEEP. And it would be great to have your true esophageal pressures, which will tell you what your transpulmonary pressures are. But if you don't have, just keep a little higher PEEP than you would for any normal patient if they have bloated abdomen or they are very edematous. Now, I did mention spontaneous induced lung injury and spontaneous mode, but if there is a lot of asynchrony, increased respiratory drive, which many ARDS patients will have, then there can be more patients self-inflicted lung injury. And so we would put back the patient on sedation till all that settles. Try keep your sweep gas a little higher. Reducing your CO2s can also reduce your drive, as Dr. Pranay had mentioned. Proning in pediatrics, we have done. There are no real studies, but you will have to see whether your patient is a responder or not. Tracheostomy, after 21 days, if the patient is not improving, then we would do a tracheostomy, but it is very risky. There could be a lot of bleed, and you'll have to stop your heparin for some time before, 4 hours before, and maybe a little later also, because that area would be raw. So if we feel that the patient is not going to move at all, lungs are not very stiff, then only we would consider tracheostomy. Otherwise, in pediatrics, we could extend for a little longer period of time. So this is a very, very good article by Martin Niebuhr in 2023. And this tells you that you have to, what are the settings? Limit your lung strain, low tidal volume, PEEP 10 or little more, as I mentioned. Reduce your mechanical power. And how can you reduce that? By reducing your respiratory rate. Limit the lung stress. So your strain and your stress, reduce your plateau pressures. Driving pressure also less than 15. So it still holds good in pediatrics also. What mode, pressure control mode is best, because in volume control, you would not know what volume really to set. And we know we want to do ultra low tidal volume. In the initial few days, we could even see single digit tidal volume. Please do not panic. Don't try to increase your tidal pressures just because you're seeing a 7 or 8 ml tidal volumes. So pressure control mode and spontaneous, you have to look at monitor your respiratory drive. Neuromuscular blocking agents routinely used, but no supportive data, but try not to use for too long, because then you'll have all your critical illness myopathy. Corticosteroids, definitely no, because there is a high risk of infection. So the role is still unclear. Inhaled nitric oxide. In pediatrics, the right heart usually improves once you put them on ECMO. So not much role in ARDS with on ECMO. If you're getting good flows, unless, of course, the patient is going for heading for transplant or so, lung transplant. So TPs on ECMO, this is something that we have used. We have not tried removing the ET tube and this helps toileting as well. Flexible bronchoscopy can be performed and is routinely performed in many pediatric ECMO centers while the patient is anticoagulated. This helps removing all the mucus plugs. It actually helps open up all your airways before you can even recruit. So definitely do this after the initial 4-5 days, because that helps early weaning. Awake ambulation. This is not in the acute period. Dr. Pranay had mentioned acute ARDS patients have a lot of inflammation. You would not be thinking of, doing awake ECMO in pediatric patients in the initial, at least 1 week of ARDS. Heading for transplant, yes, agree. Or if the patient is a lot more stable and cooperative. So wakefulness must be weighed against the risk of cannulae kinking and dislodgement in pediatrics. X-rays, please do this frequently, because look at this, the cannulae has very nicely migrated, and we do not want all catastrophic bleeding. In ultrasound of the cranium in small infants, lungs, ultrasound cranium will tell you whether there's any brain bleed. CT imaging of the lungs or the brain, so you can mobilize. Look for, this was a patient, you can see the with air leak, and we wanted to quantify the blood collection there. So that is before the VAT surgery, and that was why the chest CT was done for this patient. Echocardiography, the bedside ultrasound, pre-ECMO to know whether it's RV or even if there's LV dysfunction. If there's LV dysfunction with shock and ARDS, then you would prefer a VA ECMO. During cannulation, for troubleshooting, for weaning the patients, bedside ultrasound and echocardiography is invaluable. Nursing team, please ensure that you train all of them, and that is the most important. Monitor for infection. And you need a lot of hands when you have a patient in ECMO for turning them, for all your care, etc. Survival, from our experience, our patients that we have followed up, lung has the potential to heal after a very, very long time. So there have been pediatric patients, even in India, on ECMO for about 50 days, 50 to 60 days, and they have done well. PA ECMO complications are more than VV, and that's why for ARDS, even for patients in shock, VV is preferred. Of course, the underlying disease determines the long-term outcome, whether they're immune deficient, pulmonary hyperplasia, etc. And the more longer on high ventilatory settings, the worse the outcome. Of course, your other supportive care, all that makes a difference. So take-home message, timely ECMO for refractory hypoxemia can be life-saving. Outcomes are poor if instituted after irreversible ventilator-induced lung injury after your MODS. And VV ECMO is preferred for ARDS hypoxemia, even for those who come with a lot of inotropes and are in shock.